If there is no other question, thank you still for your presentation. I will now introduce the next speaker, Dr. Piette from Liège, University of Liège. She will give a talk about living after childhood cancer, the medical and psychosocial outcome of the survivors.
Good afternoon, and first of all I would like to thank the organizer for giving me the opportunity to share with you this interesting topic of the life after childhood cancer and the medical and psychological outcome of the childhood cancer survivors. So this is the structure of the talk. First of all, I would like to introduce some data on childhood cancer. I will then focus on theoretical aspects of the long-term outcome. In a third part, I will give some practical issue of this long-term outcome, and I will conclude with some take-home messages. So if we look at the incidence of childhood cancers, you can see that by comparison with the incidence of the cancer in adults, childhood cancer are quite rare. They account for less than 1% of the total cancers diagnosed in all ages. In Belgium, we diagnosed more or less 325 new childhood cancer per year. Here you can see the distribution of the different types of childhood cancer. And as you can see here, the leukemias represent the first cause of cancer in childhood and adolescence. And most often, leukemias are of the acute type in childhood by comparison with the adults. The second type of childhood cancer are represented by brain and CNS tumor, and then they are followed by lymphomas, soft tissue sarcoma, neuroblastomas, renal tumors, burn tumors, and all those types are quite specific to the pediatric population. Here you can see the evolution over the last 40 years of the incidence and the mortality of childhood cancer. And you can see that despite an increase in the incidence here in pink, there has been a dramatic decrease in the mortality linked to cancer in childhood. If we look more into detail, you can see that the 5-year survival was around 40% in the early 70s, and is nowadays of around 80%. This is for all cancer types. If we look now at the different cancer types, you can see that the evolution is different from one type to another, and that probably the most impressive improvement has been seen for acute lymphoblastic leukemia. Worse improvements have been seen for CNS tumors, but still there is an interesting improvement. And all those improvements have been reached thanks to more effective, but also more aggressive treatment. So for these reasons, the long-term outcome of those patients treated for childhood cancer is nowadays one of the most important topics in pediatric oncology. What does include the long-term outcome? It includes the late mortality, and I will show you that the late survival of childhood cancer survivors is worse than the survival of the global population. It also includes the devastating second cancers, the late toxicities, of course, and also the quality of life and psychological and socio-economical aspects. So it is really a global approach. What about the theoretical aspects? So first, the late mortality. And I selected this paper published in the Journal of Clinical Oncology in 2009, which is based on this cohort, the childhood cancer survivor study, which is a quite interesting retrospective cohort of more than 20,000 childhood cancer survivors at 5 years, diagnosed between 1970 and 1986. This study is funded by the NCI and coordinated through the CHR Citadelle. And here you can see the difference in the survival function estimate for the normal US population here and the cohort population. And there is an absolute excess risk of 7 deaths per 1,000 person years. What is the cause of this late mortality? The first cause here are the recurrence and the progression, and that you can see that this is the first cause until 20 to 25 years, and the curve reached a plateau. The second cause here, and you can see that there is no plateau until 30 years after the diagnosis, are the second malignancies. And other causes are represented by cardiac disease and pulmonary disease linked to the initial treatment. What are the risk factors for this late mortality? The type of childhood cancer is one of the most important risk factors. And you can see here that in red, patients with Hodgkin disease, and in yellow, patients with CNS tumors are at the most important risk for late mortality by comparison with other cancer types, for example, kidney or neuroblastoma. Other risk factors are the female gender, and this is due to the high incidence of breast cancer as second cancer. The young age at diagnosis is also associated with a higher late mortality rate, and of course the treatments are a risk factor. For example, for cardiac toxicity, heart radiotherapy or the anthracyclines, which are chemotherapeutic drugs well known for heart failure, are of course associated with a high level of late mortality. Radiotherapy and alkylating agents are also associated with late mortality through the occurrence of second cancers. What about second cancers? So as I already showed a couple of slides before, if we look until 20 to 25 years after the diagnosis, we can see that there is still an increase, and we don't know what will happen in the future. We don't know if the curve will reach a plateau or not, and so this is of course a problem. The most frequent types of second cancer are composed by bone cancer, breast cancer, and thyroid cancer. And the risk factors are once again the female gender because of the high incidence of breast cancer, the young age at diagnosis, of course the treatment with radiotherapy and alkylating agents, the type of first cancer with Hodgkin and sarcomas being at high risk of certain cancers, and some genetic predisposition. If we have a look now at the radiotherapy, you can see here the relationship between the risk of second cancer and the dose received. Here on the left side for meningioma in red and for glioma in blue, and here on the right side for thyroid cancer. You can see that for meningioma and glioma there is a linear relationship, and this is not the case for thyroid cancer. And here the highest related risk will be seen for the lowest radiotherapy dose. Now a couple of words about late toxicity. 30 years after the cancer diagnosis, the cumulative incidence of one chronic condition is of 70%, and 40% of the patients will have severe chronic condition or death due to a chronic condition. So those numbers are impressive and represent a high problem in the late outcome of those patients. The incidence and the severity are enhancing over time, and those late toxicities are multifactorial, with the initial tumor type, genetic predisposition, comorbidity, age at diagnosis, and the gender being involved. I won't go into too much detail for the late toxicity, but just to show you several important examples. The cardiac toxicity is, as I already told, associated with the cardiotoxic drugs, anthracyclines, and with the mediastinal radiotherapy, and the follow-up guidelines are to regularly assess the cardiac function by echography, especially in case of puberty or pregnancy. And we also stress the importance of the prevention for the obesity, hypertension and smoking. The problem of hypogonadism and infertility is of course one of the most devastating late effects. It is linked with some specific drugs, and we know the cumulative dose at risk for developing an infertility. Irradiation in some, either in the pelvic zone or in the cerebral or on the CNS, is also a treatment-related risk factor, and in some cases surgery is a treatment-related risk factor. The follow-up guidelines are, of course, to make an endocrinologic assessment if clinical sign or at puberty, and spermogram will be proposed according to the patient's choice. The cataract, I selected this late effect to show you that apart from the most important late effect, there are also small late effects that are encountered. Cranial cataract occurs after cranial radiotherapy, corticotherapy, or after some specific drugs, and in this case an annual ophthalmologic evaluation will be recommended. And finally, dental abnormalities, for example, are often seen in case of if the chemotherapy is given before the acquisition of the permanent condition. We have some tools in order to help us as pediatric oncologists to follow the patients at long term and to give them some appropriate and practical recommendation. Just to illustrate, the Children's Oncology Group edited quite interesting and quite extensive follow-up guidelines, and the Société Française du Cancer de l'Enfant also developed some quite interesting tool. This is in French, so I apologize, but this is just to show you the kind of tool that can help us. And you can see that depending on the type of chemotherapy, we can see, in summary of course, the type of late effects to be followed and some recommendation to be given to the patient. And here, it is also to show that specific tools have been developed and can be given to the patient. And this has also been edited by the Société Française du Cancer de l'Enfant, and they, for example, explain the role of the heart, and they also give the important signs to be followed, the recommended follow-up for the patient. And this is quite important for us because the patient is, of course, important to be involved in the late follow-up. What about the quality of life and the socio-economic status? So I won't go into too much detail, but of course the fact of having had cancer during childhood and adolescence has impacts on the social life, has impact on the school life and the employment, and some of the survivors have difficulties linked to neurocognitive defects after some specific treatments. And of course, a childhood cancer can also have psychological impact with more depressive symptoms, sometimes antisocial behavior or psychological distress. In some cases, and this is also important to say, the impact can be positive. And survivors sometimes let us know that the impact of their history has been a positive, had a positive impact on their future. What about the practical issue? Because as you saw, the theoretical aspects are well known, but how can we put in place this follow-up? And to illustrate this, I would like to share with you a small experience of my institution, the SALTO experience, which is the suivi à long terme en oncologie. The study population is composed of adult patients older than 18 years at the time of the consultation and treated in our institution between 1974 and 2009 for acute lymphoblastic leukemia, lymphoma and Wilms tumor. Patients with stem cell transplantation were excluded of our small study, and 85 patients were eligible to take part to this consultation. The design, in fact, we invited those patients by mail and phone call to explain them the aim of the consultation and to give details, because it is sometimes difficult for them to remind this difficult period. The consultations and the complementary examination were adapted to the initial diagnosis, to the treatment received, and to a potential already known sequelae. And the aim, in fact, was to assess the need and the feasibility of a multidisciplinary long-term follow-up consultation for this specific population. Here you can see that half of the patients took part to this consultation. 5% are still evaluating the need of this kind of multidisciplinary consultation. 22% refused to take part, and 22% are lost to follow-up. The median follow-up between the diagnosis and the start of consultation was around 16 years, and more than 2/3 of the attending patients didn't have any consultation in relationship with their childhood cancer before the SALTO consultation. Here I listed the different types of toxicity that we retrieved in this population, and you can see that more than 2/3 of the population that we retrieve late toxicity in more than 2/3 of the attending patients. The relationship between the treatment and the childhood cancer and those toxicity is of course sometimes difficult to assess, but still we retrieved some important toxicities such as hypergonadotropic hypergonadism, metabolic syndrome, hip osteonecrosis, stroke sequelae, hemochromatosis, arterial hypertension, and subclinical hypothyroidism. The majority of those toxicities were diagnosed during the study. So those results highlight the need of long-term multidisciplinary follow-up for adult survivors of childhood cancer, but the modalities of this follow-up are still debated and have to be better defined in the future. But what is already known, and in my opinion, one of the most important points is the multidisciplinary view and the collaboration needed for this kind of consultation. We as pediatric oncologists, we perfectly know the late effects linked to our treatments, but we are not able to examine adults and to follow them. So we need the collaboration of general practitioners, we need the collaboration of adult internists, and we of course need also the collaboration of the patient, him or herself. Another important point is the balance to be found between the standardization and the customization. Because indeed the type and the frequency of the follow-up have to be based on the calculated risk, but we have to be careful and we have to avoid useless examination, and we have to remind that we can cause anxiety for those long-term survivors. So we have to find a good balance. Another important point is to adapt a global approach, including not only the medical impact, but also the psychosocial impact. And we have to work in collaboration with psychologists and social workers. And finally, I think that we have to stress the importance of the prevention. And we often work together with nutritionists and toxicologists. So in conclusion, because of the dramatic increase in the survival of childhood cancer survivors over the last 40 years, but also because of the use of aggressive treatment, the long-term outcome of those patients is nowadays one of the main challenges for pediatric oncologists. We have to think about this long-term outcome in a global way, including medical, but also psychosocial data, and we have to collaborate with adult internists, medical practitioners, and the patient, of course. Practical issues still have to be solved to better adapt this product to the real need of the survivor. And this is the end. I thank you for your attention.
Thank you very much for your presentation. This is open to the discussion.
Yes, thank you for your interesting presentation about what happens in childhood cancer survivors. I can imagine that during your Salto experience, which is, I think, very long, what you list the number of medical problems you discovered during the Salto experience. What about the psychosocial things? Could you elaborate a little bit on that? Because I can imagine for people who have to cope for such a long time, which a quite stressful condition, that it is also, that this put a psychosocial attitude on stress.
I could talk for several hours of this point, but yes, indeed, the psychosocial long-term outcome is really important. We always propose the consultation with the psychologist. It is not really a consultation, but we ask the patient to share with us their experience in order to first assess their need of a psychosocial other consultation, and also to help patients that are currently treated. And what they say is, and that is strange, maybe for half of them they say that in fact that indeed the cancer had a negative impact, but another half tells that the cancer had a positive impact. It depends a lot on the cancer type. And I would say that patients with leukemia, for example, have a good psychosocial outcome by comparison with, for example, patients with brain tumors, for whom we see devastating effects. They also say that their sibling, in some cases their brother or their sister, have more difficulties, psychological difficulties than themselves. So this is also important to be studied. And also there is, maybe just a last point, there is also the issue of the insurance. And yes, this is one of the major problems of those patients.
We have now a case of a patient who has a neurofibromatosis with two tumors in the brain, in the truncus and in the medulla, and she has lung fibrosis, respiratory insufficiency. After a lot of debates, we have decided to go to lung transplant. Did you have ever this type of discussion? Do you have any experience? Literature is very poor about this.
Yes, indeed, and my experience is also very poor in this kind of specific experience. I don't think I have an advice to share. Really difficult. I think the most important is probably to listen to the patient and to follow his or her choice, but that's really indeed a difficult situation.
Thank you very much. Do you know in children who have survived like leukemia, where their medical conditions are relatively not as severe as other forms of cancer, if they as adults have higher rates of of divorce and problems with relationships, and if their socioeconomic status is higher or lower than their parents or than their siblings?
I don't have detailed information, but I think that in acute lymphoblastic leukemia, indeed, this is one, except the stem cell transplanted patients, I think that those patients in some cases have indeed a higher socioeconomic status than the sibling. This is once again one of the childhood cancer type that can give a positive impact on the psychosocial impact of the survivor. But I don't have in mind detailed information, but sometimes it is I don't know how to tell that in English. I apologize, but sometimes in some cases we think we will find negative impact, and in fact it can be a positive impact by comparison with the family and the sibling. Yes.
The practical organization of long-term follow-up, I think it's very difficult. Who is responsible for this? Is it the pediatric oncologist, the general practitioner, the internal medicine doctor? And where do you organize it? Is it in the hospital or at home? Is it by mail or by letters to invite the patient to come? What is your opinion?
A lot of issues, a lot of questions. We invite the patient by mail and by phone call because really it's difficult. You know, and you have to imagine that those patients have fully don't think about the childhood cancer, and that we come back with, oh yes, we think that we have to be followed, and it can be really aggressive for the patient. So we explain by phone the aim, and it is in fact the pediatric oncologist who treated the patient who calls in order to explain the patient, the aim and of the consultation. The consultation takes place at the hospital, and this is not, it seems not to be a problem for the survivors. The organizers of this consultation are the pediatric oncologists, and we send a detailed report to the general practitioners. We aim to start a study assessing the need of the medical practitioner and the general practitioner in order to exactly know what they are waiting for us, for those patients. This is ongoing. This will probably start in a couple of months, and we are currently evaluating the patient's need. Most of them tell that this kind of consultation had a positive impact and are happy. Sorry, I can refine my words in English, but are happy to be followed once again in relation with their childhood cancer. But of course, we cannot assess the need of the patient that refused to take part, and what was the impact of our call for those patients. This is also a problem that we cannot evaluate.
Okay, thank you.